Folks, I'm very happy today because I have the pleasure of hosting Dr. Adam Cifu, a colleague and a dear friend from my days at the University of Chicago, but whom I really, really, truly admire a lot. And that actually might get me in trouble because Adam steers a lot of trouble on social media. So I probably should say I don't like Adam. I can't believe that he is doing what he's doing. But I've asked him to come in because it's been about close to 2.5 years since we've been dealing with this pandemic. And I wanted to reflect about lessons learned, a wide range of things that we notice on social media and outside of social media. So really there's no agenda to this 45, 50-minute podcast, except two guys talking about what has happened in the world of COVID-19. Adam, welcome to Healthcare Unfiltered. I know you just finished rounding your own service. We are taping on Independence Day, although this episode will air in August. Just to level set, a couple of people still don't know who you are. I can't believe that, but maybe a little bit about you.
Sure. I'm a general internist. I'm at University of Chicago. I've been here since '97. I always say my wife and I moved out here then for 3 years for her to finish her training, and now we're going to die here. I'm interested in patient care. I spend most of my time still doing that. I enjoy medical education. I've done a lot of work in various roles in that over the years. And I don't really do research, but I think a lot about, where medical evidence comes from and how we weigh what's right to be doing at various times.
And that's really perfect what we're going to talk about. And I actually promised myself a while back, I don't want to do episodes on COVID-19. So this is not really about COVID itself.
Yeah.
It's really about the lessons learned from what we dealt with. Because I need someone who is balanced. I need someone who is really can say it like it is, and hopefully not in a political manner. So my first topic for today's podcast is about evidence. I think you are a big proponent of evidence-based medicine, more than me, actually. I'm a big proponent, not of real-world evidence itself, because I feel, it's hard to do RCT for everything. Tell me, how do you look, what happened to evidence-based medicine in the era of COVID-19? How would you assess that?
Yeah, boy, that's a tough question. I mean, I think we're probably not that far apart on evidence. Clearly, I've made a portion of my career both teaching and lecturing about evidence-based medicine and the importance of practicing based on evidence. But, I'm also a doctor, and I recognize that a huge amount, if not a majority, of what I do I'm forced to do without a robust evidence base, right? And evidence-based medicine, sort of by the book, going back to the beginning, is incorporating your understanding of pathophysiology with your clinical experience with the best available evidence from systematic research, right? And so I recognize that you have to balance a lot of things. And then there are times that you absolutely, can never practice with robust evidence. We wrote about this in our book, the Ending Medical Reversal book, where there's situations like, dire circumstances or rare circumstances where you just don't have the luxury to, wait for data. And in those places, you have to just say, like, look, we're going by the seat of our pants, we're doing what we think is best. And certainly that describes, the first, 3-4 months of this pandemic when we had no idea. And you can't blame anybody for decisions that were made in March, April, May, June of 2020, right?
That is true. But there's a lot of things the thing is, let's take COVID-19 as an example when it comes to evidence. We had a lot of interventions back then that we didn't know what we're doing. I mean,
right.
By the seat of our pants. At what point do you require evidence?
Right.
And do you need evidence for every intervention?
So I think what we've seen, I am going to answer your question, but I think what we've seen, if you look at what we still argue about and what we don't argue about, you see the importance of evidence, right? Nobody in their right mind is arguing about the benefit of vaccinations, right? Especially for the highest risk people, absolutely for moderate risk people. And why is that? That's because we have really, really robust evidence on the benefit of vaccination, okay? And then look, let's go kind of to the other side of things, right? Where we do really argue. You know, as crazy it is, people are still arguing about masking in public. People are still arguing about, you know, some of the crazy treatments that were recommended. And those arguments stem from the fact that we still don't know, right? And it's incredibly difficult to counsel people on the risk benefit of certain interventions, whether they be pharmacologic or non-pharmacologic, if you don't really understand the benefits and harms of those indications. So I would say, you know, the more evidence, the better. There are some things that are very, very difficult to study. I think we kind of did a crappy job studying a lot of things that we need to know about for, you know, the next 5 years, the next pandemic, but also, you know, to pat the back of a lot of the incredible researchers out there. We've actually had a lot of great research, right? I mean, I think, you know, we understand how vaccinations work. We understand the benefits of, you know, remdesivir, dexamethasone. We've really shot down a bunch of the things that people were hoping would work early on, whether it was hydroxychloroquine or azithromycin or, you know, whatever. And those are like real successes. I wish, oh, and I'll add, I mean, something that we had opportunities to study for the last 100 years, convalescent plasma. You know, I think finally we come out of this pandemic having a good sense of, at least in this setting, that convalescent plasma doesn't work very well. But there are things that I would love to have seen more research on. And I think there are questions that are still coming up. And, you know, masks is probably part of that. Like, how much does this help? And how long do we need to do this for? And what are the kind of risk measures that we should say, okay, look, this is where it makes sense to mask. This is where it doesn't make sense to mask.
So let me take a couple of examples because I want to maybe hone in on a couple of things. No one is questioning the the benefit of vaccinations. I agree at large. But I think what folks are questioning is maybe 4 topics. And I would like, again, to ask your opinion in terms of the level of evidence you need for something like this. One is vaccination in kids. So nobody is arguing whether you and I should get vaccinated.
Right.
I think the argument is maybe kids younger than 5 years old or 5 to 11 years old. That is continue to be contentious. Number 2 is the number of shots and boosters. You know, is it 6? Do I get a shot every 6 months? Do I get every 4 months? It seems to me that we should be able to study that. Like, you could take folks who've gotten 3 shots and randomize them to 4 or placebo, I would think.
Yeah.
Number 3 is infection. Like, if I have 2 shots and an infection, do I need a 3rd one or something? And lastly is the adverse events of myocarditis. Boy, oh boy, oh boy, oh boy, Adam, it is such a, if you ever bring myocarditis, you're an anti-vaxxer. So I think vaccines, I agree with you. Nobody questions the benefit at large, but whenever it comes to subcategories, it's very heated. So help me understand, as a evidence-based medicine educator, how do you counsel folks about these 4 categories?
Okay, well, so I'll give my caveat up front, right? I'm a general internist. I'm not an immunologist. I'm not an infectious disease doctor. I don't sit on vaccine advisory boards. So I'm going to kind of give, you know, what I think is common sense. And I don't think anything I say is going to be controversial. And I'm going to talk about, you know, where the trouble comes from, right? So as you say, based on actually RCT data that we have, and actually, man, just based on our experience over the last 2 years, right? these vaccinations are incredibly effective and incredibly safe, okay? And I think probably, the relative benefit at every age group and every risk category is about the same. The absolute benefit clearly falls as your risk from this infection gets smaller and smaller and smaller, okay? And so I think on the one side, you have people who are arguing, look, it is critical that every person, Chadi and Adam's age and above, right, get this vaccine, okay? And that's critical. But come on, it is so rare that the young get really sick from COVID. It's unlikely that they have long-term consequences from this disease. What's likely going to happen is they're going to be exposed, they're going to become immune, naturally. So they never have problems with this later. And there are very small, but measurable risks to this vaccine. So that group maybe, should be optional, okay? On the other side, there are people who say, look, the way to beat an infectious disease is to vaccinate everybody, no matter how low risk it is. And look, there are things like, varicella, chickenpox, right? I don't know, maybe mumps, right? That we went all in on vaccinations, not because they were wiping out populations like COVID, but because they really did interfere with, life, daily life. And it's reasonable to do that. And it's reasonable to do that without really robust evidence, okay? And I think that's actually kind of a reasonable thing to disagree with. And I actually think the disagreement is unimportant because, it's happening. We now have vaccines approved down to 6 months old, right? I think there's going to end up being a very nice line of vaccine uptake where the people who are at least risk have the lowest rate of vaccinations, and the people who are at the most risk have the highest uptake of vaccines. And that's because people are, reasonably good about reading their own risk, right? And understanding their risk tolerance. Now, I know the group who is most into the vaccine sort of blame the people who say, oh, it's a decision for, the low uptake in the low uptake group. But I'm not sure that it's a completely irrational decision, to not vaccinate your kid who's 5.
Mm-hmm. How about number of shots and boosters? So Adam Cifu, you probably gotten 3, maybe you've gotten 4th. I don't know. I guess the question is, I feel we're flying by through our pants. Like, do we even know? I mean, do I just go in September and get one and just go? I don't know.
I mean, so I think, and this may get beyond my expertise, but I'm pretty sure as a general internist that, the primary series for COVID is 3 shots, okay, right? And the primary series for a whole lot of our vaccines is 3 shots. That seems to be the thing, right? We get pretty good immunity with those first 2 shots. That does seem to wane, and we seem to get a really nice bump with that 3rd shot. I think right now where we're standing, with our current illness and our current vaccines, is that a 4th shot gives you some robust immunity against infection for about 6 weeks, fairly short-lived. And what all these shots do is not really protect us from COVID, right? It's not putting some sort of miraculous barrier around us, but it's allowing us to not get terribly sick with this, okay? And this is not absolute. Obviously, there's, breakthrough infections. Obviously, there are people in the hospital who have gotten, a full series of vaccines. But overwhelmingly, compared to where we were 2 years ago, if you've gotten vaccinated, you're going to get COVID and you're not going to get terribly sick with it. And then I think it's looking into a crystal ball, right? And the optimist's crystal ball says that we're going to continuously be exposed to this disease. we're going to continually get infected with this specific coronavirus. And it's going to be like every coronavirus we've ever come in contact with, that, look, our immunity is going to be, pretty good, but not perfect. It's going to be lasting, but not permanent, but it is going to keep us from dying of this infection. And those people will say, I'm done. I'm going to, get a mild COVID infection every couple of years, and it's going to keep me immune forever, and I'm not going to die of this disease. There are others who say, this is a different infection. We have never seen this coronavirus before, and, it's going to keep changing, and it's conceivable that in 6 months or in a year, it's going to come back in a way that we're going to be back in, March of 2020 again, with many people getting very sick. Okay. I can tell you what, my crystal ball as a sort of optimist says, but there's no reason my crystal ball is more or less right than anybody else right now. I think we're kind of guessing about the future.
But I mean, as a general internist, as an educator, you do
Yeah.
get these questions from both sides, maybe your patients or even the residents and the interns. And I think, one way is to turf that to ID, but we all know this bond between the primary care doctor and the patient is always important. So if I have 2 shots and I got COVID, which is my 3rd shot, do I need a 4th one?
So you have not gotten 4 shots, so don't try that on me. Right? I'll tell you what I say in practice, and nobody should take this as medical advice, as we always say. But I tell people that your primary series for COVID is 3 shots. Okay. Yes, I think if you've got an infection, obviously that gives you some extra degree of immunity, but you should get 3 shots, and that's where we are.
I see. So one infection does not substitute a shot, what you're saying.
Right. I think it helps, but I don't think it substitutes.
But we have no evidence that it doesn't substitute a shot.
That is absolutely true. I mean, what we see, we have evidence that an infection certainly boosts antibodies. We have evidence that infections does decrease your risk of serious complications. So I'm a believer in infections. But I think that given what we have, what we know about the vaccines, I really think you got to recommend 3 shots as a primary series for coronavirus.
Okay, 2 other things pertaining to just general things. I'm just thinking of the things I see a lot of heated debate on, and I think I'm talking to Switzerland. See, you're Switzerland, Adam. Long COVID. It seems to be that word long COVID generates a visceral reaction among people. Some folks think it's a completely made up name because we don't know what long COVID is. And some folks say it definitely exists. And it does have, so I guess 2 questions. Do we have a definition for long COVID? And what do you teach residents about or students? Like, I don't know, tell me what's long COVID?
Yeah. So I think this is very confusing and very important because, over the course of this, I've always said that, my patients, almost to some extent, there is at least a group of them who really dichotomize, right? There's a group who's like, COVID, blah, nothing, and another group who every time we make progress comes up with something else that they're worried about. So one group is out there like this doesn't exist, and another group is still isolating at home, not because they're worried they're going to die of COVID anymore, but they're worried they're going to be exposed, not get sick, and suffer the consequences of long COVID, right? I will sort of give my thoughts, and I'm not trying to convince anybody of this because, as you say, I don't think we really know yet. I certainly think that, man, there are people who have either gotten very sick with COVID or who've gotten moderately sick with COVID, who, just like people who've had any severe infection in the past, whether it be influenza or mycoplasma or urosepsis, take a while to bounce back from that infection, right? And I don't think that's long COVID. I think that's, coming back from a bad infectious disease. And what's remarkable about the last 2 years is we've had more people with bad infectious disease infection than we've had, in my entire career, certainly. That's kind of number one. Number two, this disease is weird. I don't think the disease is weird. I think it's weird because we've had no exposure to it. Where, a woman I'm taking care of in my practice now who was mildly ill, at home, no treatments. This is after 2 vaccines. And she has been, laid low for the last 6 weeks, terrible fatigue, incredibly high inflammatory markers. And this is sort of a recovery phase from infection. Again, I'm not used to seeing in my career. Okay. And then there's this sort of long, I think what a lot of people think of as long COVID, the brain fog, the weird, persistent dyspnea, the persistent lack of smell and taste. I think there's probably a spectrum there. I think there are a small number of people who do truly have some long consequence of this disease. I have no idea what the number of that is. I think the MMWR article, which pitched that at 20%, is absolutely crazy. And I say that as an internist who's, now up to between 200 and 300 of my patients, who've had COVID over the last few years. And I can count on one hand the number of people who I could say, this person still has some persistent symptoms. And I think one of the difficult things about medicine today is we've allowed people, and this will get me into trouble, but I'll say it, one of the great benefits of how we care for people is we really let people define, what their illness is, right? This is what I feel, and what I feel is truly real. A lot of people who feel terrible, and I don't know if it's because of COVID. I don't know if it's because of living through a pandemic. I don't know if it's because what the world is like today. But I'm not sure it makes a whole lot of sense to say that anybody who thinks they had COVID or maybe had COVID can ascribe every symptom they're having to COVID.
This is so well stated, and I think I'll echo that. This is it's not something that we actually know what it is very well, but a lot of decisions are made on the assumption that we know where it is.
And it's one of those things that if you said how do we study this, right? It's nearly impossible because who is your control group? And there's not a control group. You're looking at a cohort study of infected people. And those infected people have to be stratified by, their age and probably comorbid risks, right? And then they need to be followed for symptoms. And symptoms are subjective. And are those symptoms related to disease or not? Boy, this is going to be a morass.
Yeah. So in all this, in disclosure, what steered the idea of this podcast was a tweet that you put on, which is the subject of the second topic, which is masking. On June 12th, 2022,
I was going on vacation when I said...
Dr. Adam Cifu tweeted the following: airport filled with people overwhelmingly unmasked. Those that are masked mostly in N95. The wisdom of the crowd, ? Boy, oh boy, oh boy, oh boy. What were you thinking?
I don't know. I thought,
you said, and then hold on. Then you said, I am not masking in airports or on planes and will stop with patients the second I'm allowed. And I think, needless to say, you have a lot of people that responded. One of them mentioned, she said, I'll make sure that doesn't happen anytime soon, Adam Cifu. So what's going on there?
So the first tweet, which I think irritates a lot of people about me, is my favorite tweets are ones that I don't have to express my own opinion, but are often read as sort of a Rorschach test where, how people respond to it is what they bring to it. And I was asking, is it the wisdom of the crowd? I wasn't saying anything. And I honestly I don't know. I did not think it was that controversial. I'm at a point personally where I think the risk to most people of COVID, most vaccinated people, is very low. I think there are people who are at higher risk, either because they've made the decision not to get vaccinated, or they are the very, very small group of the population who are at higher risk for COVID and will always be. And those people are well protected by wearing an N95, and that's a reasonable thing to do. Without going into my medical history, I am probably of moderate risk, but my risk tolerance is fairly high. And so I am actually comfortable, doing as I said. I do think it's very interesting. And I think also we should accept people's decision making, and I'm not going to give anybody who's wearing a mask a hard time. I'm not going to give anybody who's not wearing a mask a hard time unless they know they have COVID or they are like otherwise ill and spewing tuberculosis on my plane. Those people should either not be on the plane or should be masked. I think, and you probably have other questions, I think as far as what we do in medicine from now on, I'm actually quite interested in. We've all gotten very used to wearing a mask, in the clinic, in the hospital, everywhere, right? And a poll I put up was sort of funny because it was almost 50-50 people saying, we should mask forever after now in medicine, because none of us have gotten a cold for the last 2.5 years. And we know that there are outbreaks which bring down the whole ortho clinic for a week because everybody gets the flu. And why should we go back to that? On the other hand, there are people who I don't want to spend my entire career with a mask on. And it really does take a lot out of the doctor-patient relationship. And I've felt that. My style is often to broach difficult topics by, sort of stating uncomfortable things with a smile on myself to try to disarm the conversation a little bit. And that style loses a lot with a mask on. I also take care of predominantly people over 75 years old, half of whom can't hear me very well. And to be covered up and talking like this makes our communication even worse. So I don't know what the answer is to that. But I think this is something that could be fairly easily studied to say, what is the benefit of keeping hospitals masked to a certain level of infection versus not, looking at doctor satisfaction, patient satisfaction, illness, death, so on and so forth. Where do you want to go after me after saying all that?
Well, I'm curious, number one is, why do you think, the kind of question that you asked generated such a visceral reaction and responses? Because I gotta say, I was a little bit surprised. I think it is the same observation I noticed in airports. I travel a lot, and reality is at this point, 90% plus of people in airports on the planes are not masked. And yes, the people who are masked, they usually do wear the proper mask at this point, but 90% plus, and you basically, all what you said, this is what I'm seeing.
Yeah.
But the response was really out of proportion to what I expected. Why is
that? I think that on the one hand, and I'm guessing, right? People feel very strongly about what they do, right? About their own sort of beliefs and habits and risk. Okay. And I think people are a little bit more, feel freer on social media to absolutely lay out their feelings, many of whom are anonymous. I think also I am either lucky enough or unlucky enough to have a lot of people who follow me. And so people think that if I'm expressing, an opinion or even just an observation, that maybe that comes out as amplifying something which isn't for the, as they see for the general good, and get angry about that. And I think also, there are people who are probably, and I really, this is a guess, these are hard decisions to make, right? And a lot of us aren't completely sure about the decisions that we've made because there's not great evidence behind them. And so seeing someone state maybe the opposite, kind of gets you. And I should say going into this, look, masking works to some extent, right? I've gotten through my entire career without any terrible, respiratory infections, wearing N95s into rooms with patients when I need to. I've gotten through the whole pandemic, as far as I know, seeing dozens at least of patients with COVID, wearing all sorts of masks, from just regular surgical masks up front to N95s now without getting infected. I truly believe that, man, for the first 10 months of the pandemic, in my clinic, seeing tons of people with COVID, who either I knew had COVID at the time, or more likely, they called me a day or two later saying, guess what, I have COVID. And I was protected because they were wearing a cloth mask or a surgical mask, and I was wearing a cloth mask or a surgical mask. I think in a supervised setting like that, masking works. I think what we know is that outside a supervised setting, whether it's a grocery store or a preschool or a movie theater or an airport, the masking probably doesn't work because most people wear their mask, like this or like this.
Under the chin. But including my mother, by the way, who probably won't be listening to the podcast, so it's good. But I do argue them, like, why she goes to the grocery store and right. But my question is, do you think we can actually indeed study the value of masking? I find I struggle in how do you design the trial. I understand the concept and the endpoints, but it's very difficult to assure that people wearing the mask properly. It's not like a pill you give. You are gonna, how would you study that?
Well, Chani, I think you're asking two questions. I think, if you're talking about community net masking, I think what you're studying is an intent to mask, right? You're saying, I think this community, I'm going to recommend that they mask, and this community, I'm not going to recommend that. And I think actually the behavior in the two communities won't be a whole lot different. So the endpoints won't be a whole lot different. And that answers your question. And right, that's what we've gotten from the studies of masking, is that no matter what the most dedicated maskers believe, it's not going to work in the community because we're people, we're not robots. I'm very interested, though, in healthcare settings where, I have colleagues who, if they open the door and their patient's not masked, the first thing they say is, please put your mask on, There are other people who I work with who don't do that, who, if they walk in and the patient's not wearing a mask or is wearing it around their chin, they're like, yeah, whatever, and go on with the visit. So I think actually in healthcare settings, we could do randomizations where we say, University of Chicago, Rush, and UIC, you guys lock down and go all in on masking, on the inpatient outpatient side of your medical center. Loyola Northwestern, you kind of go half measures, and let's see what the results are.
I like what you said initially, intent to mask. You just do it and just see what happens. This is really interesting. I do think it's still to this day. I still see people walking in the street with a mask on in the air, and maybe there's a reason behind it. I honestly don't judge at all, but I don't know if it's helping or not.
And I think where we need to get to, and this is hard. I try so hard to be super open-minded, and I would certainly never say anything, okay? But inside I think it, right? If I see somebody, a young appearing person out walking their dog wearing an N95, I think, what the hell? And it's, a dozen people I see, they're not all on rituximab, right? So that's a weird decision. And I have to be fine with that, right? And on the other hand, if you're that person out alone, walking their dog, non-immunosuppressed, wearing an N95, that person needs to be fine with the person, who's out for a jog, not wearing a mask, because, at this point, I think both ways are a reasonable decision.
Yeah. Well, until you hit Met Twitter.
Until you hit Met Twitter, right?
Which is our third topic. Now, we talked about evidence, we talked about COVID a little bit, and masks. Met Twitter. You've been active on Twitter for a while, and give me your general assessment of the medical community on Twitter.
I love Twitter, okay? And I think I got onto it originally just to sort of promote a book. I think I've stuck with it. Well, I would say early on, what I got from Twitter is I interacted with a pretty small group of people who shared my interests. And so I frequently found articles that I would not have read had I not been helped out by these people. I feel like now what I use it for is still a little shameless self-promotion, right? I tweet any article or any podcast or anything I write. So feeling like I've worked hard on this.
I do like your podcast.
Thank you. Thank you.
Symptom diagnosis, I love, and this is, I'm going to promote this, but this is really, it's interesting because for me as a specialist, it actually makes my brain think as general.
Oh, good.
I love it.
Good.
I do listen to it.
Thank you. S2D, the Symptom Diagnosis Podcast. I'll shamelessly promote here.
Great podcast.
So I feel like, those are things I work on. I want more people to see those. I'm proud of it. So I put those out there. I also often, when I'm writing things, if I'm sort of stuck on a question, I'll put it out there because I like this sort of brainstorming that goes on in Twitter. And I work in an academic general medicine group. Most of the people on my floor, there are usually a couple of people here at any one time. Most of them are in clinic, where I'm in clinic and they're here. And so this widens my circle of colleagues, right? So Twitter's good in that way. And there are occasional days where I have to admit, my wife says I'm crazy when I tell her this, that if I'm sitting at my desk writing all day, and I need a distraction, I'll put something up. It's a little bit controversial, so I can, have some back and forth with some people during the day. I think, Twitter is, and I think maybe Med Twitter is better than Twitter, but it's a fairly inflammatory, dichotomized place. And I put up a tweet, I think this week, which was sort of joking, but sort of true. I often have no sense of what's going to set people off and what's not. I don't tweet anything that I think is going to set people off. I'm not quite as careful as you are. You seem to be an absolute master of staying away from controversy. Because I will often put things up that I'm like, oh, this seems pretty benign. And, people will get kind of bent out of shape about it. I actually still think for me, Twitter, the benefits outweigh the harms for me. I get a lot out of it. And I think I've gotten mature enough over time that I realized that there are actually whole weeks that I'm like, you know what, I got a lot of work to do, or my mental state isn't quite robust enough to deal with people yelling at me. I'm not going there this week.
Do you think Met Twitter, that's in general, but how about Met Twitter with COVID-19? Do you feel that when you bring COVID-19 to the equation, how do you think Met Twitter handled COVID-19?
I don't think we did a very good job. And maybe that's because of how unclear it was what we should be doing, right? I think that upfront, it was helpful because we shared a lot of the data that we had quickly, shared resources, things like that. And I benefited from it because I think like everybody else, I mean, I was freaked out, late March, early April 2020. I think what's happened though is that because there are a lot of things which we lack data, a lot of physicians have really become advocates, on both sides. And when you're advocating for a stance, you need to abandon the nuance and the uncertainty, which is kind of part and parcel to practicing medicine, right? And I think, excuse me, this jump, but the reason that people like Dr. Oz drive us all crazy is it's very easy to sit there with nobody talking back to you and say this. And on Twitter, you can sort of say this, and a lot of the people who agree with you gather around and prop you up, and maybe you mute the people who you don't want to hear from. While when you're in the room with a patient, I think most of us are just working to come to a workable agreement with that individual about how we're going to behave and what's right and how we're going to go forward. And that's lost in this sphere.
I mean, it's interesting you bring Dr. Oz. It generated a question in my mind. Clearly me and you have the same idea, the same opinion of Dr. Oz. But one thing I would say, the fact that Dr. Oz ran for the Senate on the behalf of the, I don't know if he won the primaries or not, to be honest.
He did.
And he won the primaries in Pennsylvania, it looks like. And the fact that the Met Twitter community denounces Dr. Oz, which I tend to believe appropriately so, does that mean that us in Met Twitter are out of touch with the American public, with the average man walking on the American street? I mean, here we are, everybody on Met Twitter saying this guy is a quack, and he just won the primaries in the state of Pennsylvania. Isn't there a disconnect?
I mean, I don't think I could talk for Med Twitter as a whole, but I can certainly talk, to my bubble on Med Twitter. I'm like a, liberal academic lefty, right? And I try really.
Or a central or centrist. Come on.
Right. Yes, I've been moved to the center because of what's, happened to my people. And I try really hard to, keep my bubble pretty open on Twitter. There are people who I feel like, boy, it would be better for my mental health to unfollow this person or block this person. But, I don't block people, so I can keep hearing this. But right, I mean, you see what happens. You go to an airport, you see what happens in elections. You see where either a majority or a large minority of the country stands on issues, and you realize, come on, we're not speaking for most people. And I guess you can say, well, it's because we're smarter than everybody else, but come on, that's not true. And I think, it's a democracy. It takes a lot of work to understand and not vilify those people. And then there are people who, vilify you for not vilifying the other side. There's a great line from a song from the new Wilco album, which I'll kind of get wrong, but it's like, it's like, how do you talk across the aisle when the other side is crazy? It's something like that, which I think is brilliant. It's hard. I'm certainly not going to answer this.
and both sides now believe the other side is crazy, which is really,
Right.
but I do feel that there is a little bit of, I mean, I'll say this, although you know me, I try not to honestly offer my own opinions, but I do think sometimes Twitter and mid-Twitter is out of touch with reality. And I tweeted a couple of times, I said, Twitter is not the real world. And, I mean, examples of this, even, in a pandemic, when Omicron is coming, let's just stay home and watch Netflix and order takeout. Well, you know what? Somebody has to deliver the food to your door. I mean, it just doesn't appear at the door. So yes, you may be privileged to be able to order takeout, but nobody, not everybody can order, groceries and afford groceries and all that. I mean, I think that's really where I feel that our recommendations occasionally are not pragmatic, and it's a little bit out of touch with the average person who is maybe not a doctor or a lawyer.
I'm going to push back a little bit. Not to say us doctors are so wonderful, and not to say, hey, don't lump me with the lawyers. But I think one of the wonderful things about medicine is, we don't have that option, most of us, to stay home and watch Netflix, right? I had 2 weeks where I saw patients on video, which made me absolutely crazy. And otherwise, I've been back with my job, basically my job. And I think it's helped me because it's kept me grounded in what is actually the infection risk? What does COVID look like among people who have gotten sick with COVID? And I think it's one of the things that has really helped me with, as you say, long COVID, is that, like, boy, 90% of the long COVID articles I read just don't pass the sniff test. It's just not what I'm seeing. And people will say, like, oh, geez, Dr. Cifu, you're supposed to be all about evidence-based medicine. And here you are, spewing anecdote. Well, that's, as I said, part of evidence-based medicine is clinical experience. And if I'm reading something that has absolutely nothing to do with my experience, I got to question it.
Yeah, no, very good point. And I appreciate you saying that. It is true that probably the majority of physicians who were able to, were frontline workers. I mean, absolutely. My last topic, and you've been amazingly generous. I love talking to you, Adam. It's a lot of fun.
Absolutely. Same on my side.
It's politics, and it's not really, it's my sense is, and part of the reason I'm a little bit more Switzerland than you are on Twitter is I feel Twitter is so heavily engaged in politics, not in policy. Now, I'm not against you. We all need to have our political views, right? I mean, you at some point, hopefully, you go and vote and exercise your right as a citizen. But I tend to feel that we need, as physicians, to be focused more on policy and evidence, and I think we mix all of that together. Now, is it perception from me, or do you really find the same? And if you do, how do we change that? Because I think it's a slippery slope once we start mixing those.
I think the only other time that I've truly gotten into trouble on Twitter was, about this. So maybe you're just trolling me.
I'm not, I swear.
But, I think we all choose how we engage, right? I am, and I admit this is I'll just say it, I am not an advocate. I advocate for my patients. A lot of people will say, oh, Dr. Cifu, that's, your privilege, as a cis white gendered male, you don't have to advocate. It's just not who I am. I can't do it. I'm crappy at it, But look, we as doctors have an important role, I think, as advocates and politically, right? And if we're not filling that space, someone's going to fill that space. Now, I think probably what you're getting at, which I really do sympathize with, is that we as physicians, still in this society, we carry a ton of respect, a ton of privilege, right? And a lot of that is based on, being sort of neutral, data-driven, caring for the individual kind of people, right? And I think there's a sensitivity among some, and maybe it sounds like among you, is that, listen, if we turn into just another, policy supporting, spokesperson, that we're going to lose some of that respect and some of that privilege. I'm at a loss about that. Like, I on the one hand share your concern. On the other hand, like, I don't want somebody who doesn't know what they're talking about, trying to make policy that affects not only me, but my patients. So I don't know what the right answer. I think the right answer is that I certainly hope that people who are, in medicine, caregivers of any kind, if they choose to become advocates, politicians, political spokespeople, that they are really mindful of their profession as well.
I guess what I fear is that the political views of someone might cloud their policy decisions. And I think physicians, I still would say physicians should be above the fray when it comes to politics, because we are trained, right? When you see a patient in your clinic, they could have completely different beliefs. They could be, you can't judge them. You have to treat them as a patient and understand their views and be advocate for your patient. You may not agree with the views of your patient, but you respect that and you advocate and you act on their behalf. And if you feel strongly about certain political views, I do feel that might cloud some judgment. And I hope not, but that's my...
Yeah, I know that doesn't worry me at all. And I think, through a career of, my own practice, being closely involved with a lot of colleagues, both, in the workroom, having a beer on the weekends and watching them interact with patients, I think we are really good at separating that and saying that, like, you're my patient. I don't care who you are, I'm going to care for you. And I think that's so, such an important part of, like, our ethics and our code, that we do that. And I think that anybody who doesn't do that, should truly find another job. And I think that because of what we do and because of how key it is to how many of us, like, see ourselves, and it's why so many physicians do so badly in retirement, because they're like, I've defined myself by, by this occupation, and then they go into retirement and they're lost. That a lot of people have such strong feelings about what they do that they feel like it needs to bleed over into the rest of their life, into politics and advocacy, things like that. So I worry I worry less about politics going into the exam room, and maybe more about when politics comes out of the exam room into politics, how that's going to affect how we're viewed.
And I do remember, by the way, now why you thought I was trolling you, because you did, I do now remember, now I'm trying to think, I do remember something you put out there about advocacy and so on. See, that's what the title of this is, Adam Cifu Steering Trouble, because you always do that. Adam, this is great. I really enjoyed, and I want to let you go back. Hopefully you have some time left to enjoy 4th of July weekend. But I have to ask you this. Is there a book coming for Adam Cifu?
So I am working on two things, both of which are too embryonic, if it's okay to say embryonic in the post Roe v. Wade decision.
We'll find out. We'll find out.
Yes.
Blocked.
To discuss, but I am very excited about both of them, but I think they are both on the 5 to 10 year spectrum.
Wow, that long.
I see them both as being my swan song in this career.
Oh my God. But can you share, like, is it book? Is it something like that, or more, or
Yeah.
maybe share with time?
No, man, I want nothing to do with COVID. I can't believe I'm even speaking to you about COVID. No, one is going to be an honest attempt at trying to, help with kind of lay medical literacy, which I think is just so critical. The number of patients who I see who are, wise, intelligent, well-educated people whose own health is compromised by low medical literacy, I think is an issue, and I'd love to do something about that. And then the other thing is, I've written sort of tons of reflection pieces and have spent half my time on service these days telling stories, and I'd love to figure out a way, to talk about important parts of the doctor-patient relationship over a career.
I love your writing. Amazing. For the first idea that you have, I'm actually working on something specifically for cancer.
Great, wonderful.
Cancer. So we'll see how
we'll have to talk.
Yeah. All right. Well, Adam, this was amazing. This was excellent. Wonderful. Thank you so much for spending some time with us. Appreciate it.
Shadi, thanks for having me. We'll talk soon. Okay.
Absolutely.